Yeah, ma'am.
Okay. Good evening, everyone. I am Dr. Baisakhi Bakat. I am a consultant in Ramakrishna Mission Seva Pratishthan and Manipal Hospital. Today, I am going to speak on management of frontal sinus. So, what are the indications of pathologies, or what are the indications of surgeries involving frontal sinus? These are chronic rhinosinusitis with or without polyp, CSF leaks, benign and malignant tumors of frontal sinus, trauma, osteomyelitis, and mucosis. The medical management of all these pathologies involving this frontal sinuses are similar to what we manage the medical management of other sinuses. But the surgical management of frontal sinus surgery is very different. It is very challenging as compared to the surgical management of other sinuses. And what are these? Why this is challenging? Because of the anatomical orientation, which is very difficult. There's a wide variety of variation in the anatomy that exists. Because of this narrow ostium, this difficult trajectory, and all this leads to a difficult surgical access to this area. In addition to this, all these factors make instrumentation in this trajectory also difficult. So, because of the inadequate surgery or difficult surgery, there is a tendency of recurrence of pathologies involving this sinuses. The treatment also ranges from long-term medical treatment to long-term surgical treatment. So, coming a little bit to the anatomical orientation, as I've said earlier, frontal sinus is a sinus which lies quite anterior to other sinuses. It has a narrow ostium, it has a narrow trajectory, a narrow drainage pathway, which is frontal recess pathway. The configuration of the frontal recess is regulated by another structure, which is known as uncinate process, as we all know. The attachment of the uncinate process usually determines the drainage of the frontal sinus. For example, here where I am pointing, if the uncinate process attaches to lamina praepatia, the drainage will be medial. If this attaches to the attachment of middle turbinate to the skull base or to the cribriform plate, the drainage will be lateral. Along with this, there are distribution of a huge number of cells which define and decide the disposition of the drainage pathway. For example, see, these are the cells which lie usually anterior to the frontal recess and thus pushes the drainage posteriorly. So, in order to study these cells in details and to have a uniform distribution, uniform terminology of these cells, Wormald group in the year 2016 have come up with this classification, which is known as International Frontal Sinus Anatomy Classification. So, according to it, these group of cells are divided into an anterior group of cell. These anterior group of cells are together are Agar cell, supra-Agar cell, and supra-Agar frontal cell. So, what these anterior group of cells do, they push the drainage of the frontal sinus posteriorly or posteromedially. How it happens, we'll see. Till now, if my voice is okay for everyone. Hello? Hello? Am I audible? Hello? Yes, ma'am. Okay, sure. Thank you. Thank you. Thank you, Prabit Kaur.
Ma'am, you're audible, ma'am.
Yes, yes, yes. Thank you. So first coming to the most important cell and the first cell which we need to identify when we are embarking on frontal sinus surgery or when we are trying to read a scan before frontal sinus is Agar cell. So how, where is this Agar cell? How to locate it? If you are going through a SAD scan, please try to identify frontonasal process of maxilla. The cell which is most anterior and just behind the frontonasal process is Agar So here this is Agar and other landmark is what? Try to look at cell which is anterior to the attachment of middle turbinate to the lateral nasal wall. See again coming to the axial scans, frontonasal process of maxilla, the cell just behind it will be the Agar cell. So with this slide, I want to impress upon the fact that the need of CT scans in all three sections, especially axial and sagittal, is very important when we are trying to do a frontal sinus surgery or we are trying to read the drainage pathway of frontal sinus. So agonized cell done. So coming to other anterior group of hair cell, which is supraagar cell or supraagar frontal cell. So what is supraagar cell? Supraagar cell is any cell which is just above the agar nasi. Again, identifying the agar nasi, frontal nasal process of maxilla, agar nasi, cell above, supraagar. Again here, attachment of middle turbinate, cell, agar, above it, agar nasi cell. Again here, agar nasi cell. Agar nasi cell, cell above it or cell behind it is supraagar. So these are the cells which are into the above the agar but not going into the frontal sinus. So these are the supraagar cell and not supraagar frontal cell. What are supraagar frontal cell? These are the cells which are above the agar nasi, frontonasal process of maxilla, agar cell, above agar, supraagar cell, but supraagar frontal cell. Why? Because they are entering into the frontal sinus. Okay, so we can see how, supposing this cell, if this cell is enlarged, where it will push the frontal sinus drainage pathway? Posteriorly. See, posteriorly. Here, if this cell is enlarged, where it will push the frontal drainage pathway? Medially. Again here, if this cell is enlarged, supraagar frontal cell, if this is enlarged, where it will push the drainage pathway? Posteriorly. Okay, so done. Now we are coming to posterior group of cells. What are the posterior group of cells? These are suprabular cell, suprabular frontal cell and supraorbital ethmoidal cell. There are some medial cells also which are very easy to identify, frontal septal cells. But posterior group of cells we need to learn it thoroughly. So these posterior group of hair cells, when these are enlarged, they will push the frontal drainage anteriorly. How? We will see. See, again, frontonasal process of maxilla, agar, bulla ethmoidalis. The cell above is suprabular cell. So if this is enlarged by any chance, so where it will push the drainage, this is frontal sinus, where it will drain? This way. So anteriorly, okay, anterior drainage of frontal sinus. Here again, this is middle turbinate axilla. Sorry, this is middle turbinate, agar, bulla behind, and suprabular. So if this is for example, coming here, so these are suprabular cells. Again, coming to other cells which are suprabular frontal cell. These are also suprabular cells. See, again, frontonasal process of maxilla, agar, bulla, suprabular cells. These are the suprabular cell, but they are entering into the frontal sinus. So what they are known as? Suprabular frontal cell. So if by chance this cell is enlarged, where it will push the frontal sinus drainage pathway? Anteriorly. So this is the disposition, or this is the way these cells change or configure changes the drainage of the frontal sinus. The last group of hair cell, which is a determinant of drainage pathway, is supraorbital cell. Supraorbital cell is important because by the terminology, supraorbital cell is any cell which is above orbit. This is orbit, above orbit, in relation with anterior ethmoid artery. This is the anterior ethmoid artery. It may lie anterior or posterior to anterior ethmoid artery, but it will always lie in the posterior wall of frontal sinus. This is here the frontal sinus. This is the frontal sinus. This is supraorbital cell. So why identifying this cell is important? Because sometimes we may just open up supraorbital cell and we may be confident that we have opened the frontal sinus also. So we need to go thoroughly to the scans, that whether there is a supraorbital cell present, whether it is small, whether it is big, and then we need to complete our procedure. So again, coming to the frontal sinus surgeries. So as we all know that the surgeries of any other sinuses are evolving from external to more endoscopic, more conservative, more mucosa preserving. In the same way, frontal sinus surgeries are also evolving. They have evolved from procedures like Lothrop, osteoplastic flap, frontal sinus obliteration, and mini trephination to completely endoscopic procedures. For example, endoscopic sinusotomy. Now, endoscopic sinusotomy is now also being divided into frontal recess procedures only and frontal sinus ostial surgeries only. Axillary flap technique, draft techniques, frontal sinus rescue procedures, balloon dilatation. These are all conservative endoscopic procedures being practiced. But now, in an attempt to get a good outcome, and to reduce invasiveness of certain procedures like draft, and to preserve the normal architecture involved mucosa, the draft procedures are also being modified, like modified hemilothrop, modified minilothrop, and subtotal lothrop. So coming to the classification of the surgeries which has come in 2016 by Wormhole Group is they are dividing the frontal sinus surgery into frontal recess clearance, and frontal ostial surgery. Correct? Frontal recess and frontal ostial surgery. So what do we do in frontal recess? Grade 1 is just removal of the cells in the frontal recess. Grade 2 is removing the cells in the frontal recess and also the cells obstructing frontal ostium but not touching the frontal ostium. We will not touch frontal ostium at all in frontal recess clearance. Grade 3 surgeries is what? We are clearing the recess and the cells which are going through the ostium into the sinuses, but we are not touching the wall. We are not modifying the dimension of ostium. Matlab, we are preserving the mucosa of ostium. We are not touching the ostium at all. The second category of surgeries is frontal ostium surgeries, frontal ostium enlarging surgeries to be specified. So these are mainly the draft procedures which we used to do earlier. For example, grade 5 is draft 2B. Okay, so removal of the frontal sinus floor from nasal septum to lamina preparation on one side, and grade 6 is total removal of the frontal sinus floor. So starting with grade 0 surgeries, yes, grade 0 is also a surgery which is defined by this group, where grade 0 is actually balloon sinuplasty, where we can see this is a video. Yes, there's a video where we will not remove any tissue at all. We will not remove any mucosa, will not remove any tissue, we'll just dilate the frontal recess pathway. How? This is being done with a balloon sinuplasty technique. So this is the guide wire. This is the guide wire over which the balloon is loaded. So after guiding the guide wire into the frontal recess and trans-illuminating the frontal sinus, we confirm that the guide wire is in position by the trans-illuminating the frontal sinus, and we'll see the trans-illumination over patient's head. Now the balloon is being inserted. See, and now it is being inflated with the help of water. So what it does, as the balloon is inflated, it induces microfractures in the cells in the region lying around this recess area and dilates the area. So what are the advantages of balloon sinuplasty? It's an office procedure, can be done for critically ill patient. It can be done in acute frontal sinusitis when we want to drain the pyocele, and in revision cases sometimes. What is the disadvantages? It is of course associated with a learning curve, not always successful. There's a chance of barotrauma. So there are lot of literatures in the literature available where they are describing this technique, a safe and reliable technique, but only to be done after a maximum medical therapy has been given to the patient and in the medical therapy have failed. So that time only we can do this. So coming to grade 1, 2, 3 kind of surgeries. So this is a video where we can see after removal of our agar cells and other cells which are blocking the frontal recess, we can see there's a, yes, we can see the anatomy inside. Yes, see, the whole blob of allergic mucin is coming out. But the important point which I want to impress here, we have not touched the mucosa over the around the ostium, in and around the ostium. We have completely preserved it, just remove the cells which were obstructing this region. We have not touched the mucosa at all. In contrast to that, this is frontal sinus ostium enlarging surgeries. I'm sorry for this marker of this app which I have used. So we are trying to do an draft 3 here, where first I'm trying to take the axillary flap, an inverted U-shaped flap, raising the flap up to the first olfactory nerve, and after identifying the frontal ostium, I have tried to drill out the bone surrounding it with my limits being lamina praepatia here, septum bone of the septum here and removing the floor of the frontal sinus. This is the remnant of the middle turbinate. Sorry, this is the remnant of the middle turbinate. See, this procedure is enabling us to remove the allergic mucin which has collected into the lateral part of the sinus. So what are the complications? CSF leak or vital injury, persistent disease, vascular injury, mucocele or vestibular stenosis due to heating of the nasal vestibule during draft procedures. So, sorry, what are the causes of revision frontal surgeries? These are due to any remnant frontal recess cells or a retained uncinate process, or if there is a lateralization of the middle turbinate. And sometimes there is post-operative stenosis of the frontal sinus outflow tract also due to scar tissue, synechia or osteogenesis. So what is the answer to this? Now we are trying to modify our endoscopic procedures and adding finer details to improve the outcome. So what are the options we have? Axillary flap technique. What we can do here, excuse me. So axillary flap technique is nothing. We are just trying, in the axillary region, we are trying to take a flap, which is a triangular flap, posteriorly based, and now punching out the bone from this area, we can we can get access into the frontal drainage pathway using 0-degree endoscopes only. So this is the advantage of this technique. Now coming to the modifications of draft, as I have told earlier, what is draft? Draft 1 is just clearance of this frontal recess cell. Draft 2 is this thing. Draft 2 is removal of the floor of the frontal sinus from lamina preparatia up to middle turbinate. Draft 2A actually. Draft 2B is removal of the frontal sinus floor from the septum up to lamina preparatia, and repeating this procedure on the other side is what we know as draft 3 or modified Lothrop. So what are the modifications of Lothrop? Here, this is known as modified hemilothrop. This is being done for a pathology which is located far lateral. For example, this is a type 4 supraorbital cell. So in order to access a pathology like this, what we are doing type 2, draft type 2B on this side. Along with that, we are doing a superior septectomy. So with the help of this access, we can introduce our instrument, and with the help of this nostril, we can introduce our scope and access this pathology easily rather than going for the external procedures. Another procedure is modified mini Lothrop. When it is done, this is done when we want to get access to the contralateral side, and which is not possible due to prolapsing of the orbital content or fat, or there is extensive scarring and we are not able to get an access to this, or due to neoosteogenesis. So what we are doing, we are again accessing this thing from the contralateral side. We are doing a draft 2A and removing the intersinus septum, and then accessing the lesion on the contralateral side. Is based on the idea that we are trying to access lesion on the other side, but we want to preserve the drainage pathway side. So what we are doing, draft 2B, we are doing the whole of the floor is being removed. Superior septectomy is being done. Intersinus septum is also removed to get a wider access and for post-operative surveillance. But in the other hand, we are preserving the frontal recess drainage pathway untouched, and on the other side, we are preserving it. So what are the intricacies of Lothrop? It has totally replaced osteoplastic flap technique due to it is always associated with reduced morbidity, improved cosmesis, and improved endoscopic surveillance. Although it has a high revision rate in aspirin-associated respiratory disease and eosinophilia. What are the complications associated with it? Post-operative cellulitis over nasal bridge due to drilling and nasal vestibular stenosis. So this is an important topic which has been asked in DNB theory exams off and on, which is frontal sinus rescue. What is this procedure? This is done in case when there is a restenosis of the frontal. This is restenosis of the frontal pathway due to lateralization of the remnant of the middle turbinate. So what do we do here? First, we detach the remnant of the middle turbinate from lamina preparatia. We try to raise mucoperiosteal flaps on the both side. Then we remove this bone and this mucoperiosteal flap. This a small bit of flap and bone is removed, and this mucoperiosteum is again draped over the other side to create this end result. So this is a important procedure and an often asked question in DNB. What are the intricacies in it? This needs a very delicate approach because we are raising mucoperiosteal flaps from very fine and delicate structures. For example, remnant of the middle turbinate. It needs an angle endoscope. There is a chance of skull base injury and CSF leak, but the advantage being the frontal sinus recess pathway is preserved in a nice way, and you are also addressing the residual middle turbinate. So coming to the external procedures. So what were the external procedures being practiced earlier, which were stenting, trephination, osteoplastic frontal flap, or cranialization or obliteration? So is there a relevance of external procedures now? So there are many literature which are describing these external procedure to be an adjunct or a combined procedure done for some indications like neo-osteogenesis of frontal recess, frontal osteomyelitis, mucocele, and some of the remnant type 3 or type 4 cells. So these are the indications where these external procedures can be combined along with endoscopic procedures to achieve a good outcome. So starting with the frontal procedure, first stenting. So stenting is usually done. There is no fixed regimen or guideline or an accepted criteria for frontal sinus stenting, but it always depends on a surgeon's perspective when he wants to do it and the operative scenario. So the only criteria which has been predicted till now, if at the end of your procedure you are attaining a new osteum of less than 5 millimeter, then it is better to go stenting at the same sitting. So what are the stents available? These are double J stent, frontal sinus stent, which are drug-eluting stent also. These are the examples. This is a kind of drug-eluting stent, which may release steroids also, doxycycline sometimes. So, and this is a silastic T-tube kind of stent. This is a silastic with a reinforced with a mesh. This is Rain's self-retaining silicon stent. This is a drug-eluting stent. This is a spacer which is associated with some micropores, which helps in creating a space also, and for disposal of the drugs also, which we are using as an antifibrotic agent at the end of the surgery. What are the complications associated with this stent? Infection, pain, edema, or obstruction of the stent. Coming to the next procedure, which is mini trephination. It is also an adjunct in difficult situations like when we need a rapid drainage of the pyocele during osteomyelitis, or a laterally based mucocele or polyps, or dissection of when we need a dissection of type 3 or type 4 type of cell. So this is a small video where you can see a procedure being done. Here first what we do, what are the landmarks? Landmark is actually we take from the midline, we take an incision lateral to about 1 centimeter in the supraorbital vein. We make a stab. Through the stab, we first introduce a drill guide. A drill guide is being placed, see, with a skin protector. This is the drill guide. Through the drill guide, we introduce drill bit along with copious irrigation. See, this is the drill bit coming. And just touch it for a few seconds along with copious irrigation. After we have done that, we introduced a drill wire through it. And over the drill wire, we pass on our frontal cannula. And along with that, yes, we can irrigate the frontal sinus with the help of this thing. And before doing all this procedure, we aspirate. After the procedure, we aspirate to check whether we have entered frontal sinus only or we have entered the brain. So if the blood or pus comes, then it is fine. If just a clear fluid is coming, that means we have entered the brain. And here you can do other procedures from nasal, from the endonasal side. So what are the complications? Infection, blockage. It may give an cosmesis is an issue. Sometimes bleeding may happen, and if there is an inadvertent entering into the cranial cavity, it may lead to CSF leak, or in sometimes it may lead to proptosis also. Coming to osteoplastic frontal flap, with or without obliteration, what are the indications? When there is a complete laceration of the nasofrontal drainage pathway. There is complete fracture of the frontal sinus, both involving the anterior and posterior table. When we are dealing with the neoplasm which is involving the sinus, and when there's a previous complications of previous frontal fractures like mucosis. So in these cases, we do osteoplastic frontal flap. So there are different type of incisions which we can take. This is the incision. There may be a brown incision also. So we have taken a skin incision, trying to raise the skin and subcutaneous tissue, and then we raise the flap. After raising the pericranial flap, either we can take a X-ray view, a Caldwell 6-foot Caldwell view X-ray as a template for marking the prominence of the frontal sinus, or nowadays we can use image guidance, or we can use CT images also, coronal images also we can use and mark where are the pneumatization of the frontal sinus and drill out the area, marked area, and we can remove the pathology through that. If there's a fracture, the bony fragments are being removed, can be removed, or pathology can be removed, and then at the end of the procedure, after removing, if you want to obliterate the sinus, you have to remove the whole mucosa, obliterate with fat or some other materials, and then you can, in case of fracture, you can put up a titanium mesh and close it in layers. So what are the pre-op requisites? As I said, CT scan or image guidance or a transformation technique to mark the pneumatization, or a 6-foot Caldwell view can also be taken. Caldwell view can be taken. What are the complications? Bleeding, anesthesia, damage to the adjacent structures, forehead deformity can also happen, scar, or forehead numbness or brow weakness can also happen. So frontal sinus obliteration is nothing but obliterating the frontal sinus after you are doing the procedure and removing whole of the sinus mucosa. Different materials are available. For example, adipose tissue, bone, temporalis fascia, gel foam, or oxidized cellulose can be used to obliterate the cavity. So coming to the next challenge in when we are doing frontal sinus surgeries are instrumentations. Why I am telling this as a challenge? Because in case of frontal sinus surgery, we operate keeping our instruments at a level above the endoscope. While in other sinus surgery, we are keeping the instrument below the endoscope, and that to an angled endoscope and an angled instrument. So the situation is quite different when we are working than other sinuses. Along with angled endoscope and angled instruments, other instruments like mushrooms, angled kerosene punches. These are the instruments which are usually need to be used when we are dealing with frontal sinus surgeries. Post-operative care. Post-operative care in case of frontal sinus surgeries are as important as our planning and our intraoperative steps or intraoperative surgery, intraoperative care what we have taken. Both saline irrigations or steroid irrigations can be taken after the surgery to maintain the cavity. Usually, a number of molecules can be used as steroid irrigations, which are budesonide, betamethasone, mometazone, fluticasone. There are a number of molecules which can be used. Post-operatively, there should be thorough post-operative debridement of the crust or blood clots, so as to let the newly created osteum heal, let the mucosa stable, which usually takes 12 weeks to settle. So the take-home message of this presentation will be: endoscopic frontal sinus surgeries have now become the standard procedure. There is, of course, a limited role of external surgery. They are not completely abandoned. In some cases, like acute trauma or recurrent cases, or there is a recurrence of laterally located mucosis, or when there is a lack of image guidance in your institution. But it is always associated with a steep learning curve. Thank you. So any question here? Thank you, Anuj. Is there any question? So now I have noted down some frequently asked question in DNB theories. Okay, Rati Priya, about the frontal rescue procedure. Yes, it's an important question in DNB. So I'm going back to the procedure. Yes. So maybe I'll maybe I'll give my email. This thing I can send you this paper. So amongst various causes of frontal sinus, recess surgery failure, one important cause is okay. One important cause is the lateralization of the remnant portion of the middle turbinate. So this is the remnant portion of the middle turbinate. This is lateralized, there's an adhesion, and now the frontal sinus is not able to drain. So what we do here, this remnant is being detached from this lamina papyracea. This mucosa is removed, or this area is denuded. This remnant bone is also removed, and this mucosa, little bit piece of mucosa, is redraped over this region. Over this region, see, over this region. So now we are removing the excess bone also, excess mucosa also, and if we are not touching this thing, we are not damaging that much, then this will be a good outflow tract to be maintained. Frontonasal process of maxilla, somebody was asking. So that is a easy technique for yeah, this one. So in axial scans, the first bromine-prominence, first lateral bromine-prominence that you come across is frontonasal process of maxilla. The most anterior cell is usually, and an upper level, is usually agonizai. So yeah, you try to identify agonizai in all the scans which we do. Here, this is the frontonasal process of maxilla. The cell behind it is agonizai. Most anterior, just behind the agonizai. Most anterior, just above the attachment of middle turbinate to the lateral wall of lateral nasal cavity. Yes, any other question? Can so PPT here, ma'am. Okay. Uh, I don't know how to share, but I'll ask them and share. Maybe they are taking. Thank you. Okay. Thanks, Anubhav. Okay. Then I'm going back to my whatever I had prepared. The frequently asked questions which I've collected from previous DNB papers is Dr. Kamini. Thank you, Dr. Kamini. Yes. So the frequently asked questions are this uncinate process attachment and its drainage. How it the diagram is very important. Usually it is asked. Okay, okay, Arpit, I'll try. I'll see how this happens. Maybe I'll put up my email here and I can send you the videos. So depending upon the attachment of uncinate process. Okay. Attachment of uncinate process, how it affects the drainage of the frontal sinus. This is an important question. Frontal group of cells. Thank you, sir. Frontal group of cells and this thing. External procedures, frontal sinus. These are also some questions which I have come across while going through the previous paper. Frontal rescue procedure is already I have explained. That's an important question that is being asked. And frontal sinus fibrous dysplasia. Often the question is being asked, and the answer to that will be always the combined kind of approach, depending upon the extent of the extension of the pathology. You have to go for a combined approach. You have to enumerate the procedures like I have done. And balloon sinuplasty, of course, balloon sinuplasty is coming as a big question in recent advance and everything about it. Its advantages, disadvantages, what are the technique, how to do it. All these are the questions I've collected. So here, if there's I'm not actually able to see the chat box here. If I've used, I'll put my mail here, email ID if that is possible. Okay. So people who are interested to getting in PPT, they can contact me in this mail account, and I'll send them the link to the video or hmm, I think I've Frontal rescue. Yes. Okay. So at the end, maybe I
So,
hello.
yeah, ma'am. We will wait for a few more minutes, ma'am. 1 or 2 minutes. If
Okay.
there is no query, we
Sure.
can wind up.
Sure. So a slide which I didn't play there, if the attendees are there, I want to end this presentation with this slide, which is the yes, the philosophy of frontal sinus surgery. What is it actually? So frontal sinus surgery. Now we know that frontal surgery is not about only frontal sinus or frontal recess. Frontal recess surgeries are different. Frontal sinus surgery is different. You have to embark upon frontal surgeries only after giving maximum medical treatment. You have to when a patient comes with a sinus problem, you have to see what are the previous medical or surgical interventions were done for the patient. You have to give a take a thorough note of what were the procedures done earlier. So it has to be frontal surgeries have to be taken up only if there is a symptomatic patient is presenting with symptoms of frontal headache or something, and there is radiologic evidence and there is expertise to deal with frontal recess or frontal ostial surgery. Also, whenever we see frontal recess pathology, you have to clear other transition spaces also, like hiatus semilunaris and ethmoidum infundibulum. All these you have to clear, and then you have to go upon clearing the frontal recess procedure. And as I've shown in the video, uh, okay, first two slides. I've shown in the video, you have to be very, very conservative around while we are working around the frontal ostium. So this is the main philosophy behind doing frontal sinus surgeries. I think this was the first slide. Yeah, this was the first slide. These are the indications of frontal sinus or recess surgery, which is chronic sinusitis with or without polyps, CSF leak, benign or malignant tumor of frontal sinus, and in case of comminuted fracture of frontal sinus involving maybe anterior and posterior table, osteomyelitis, and mucosis. This was the first slide. This is the second slide. This is the frontal sinus, narrow frontal ostium. This is the frontal sinus drainage pathway. This is the uncinate process. This is hiatus semilunaris. This is the middle turbinate, attachment of the middle turbinate. There will be organizi here. Thanks, Dr. Sindhuja.
Ma'am, one query from Dr. Rakib Priya.
The axillary flap. So actually, axillary flap is a technique. It is just to enable, we all are not well versed with using 70-degree scope. So if you want to work with a 0-degree scope and have that view, a wide view, so that can be done by this. This is the slide. You can refer to the Warmer book for axillary flap. So this is nothing but, yes, this one. Yes. So this is just uh, after you have removed the uncinate from here, and now you want to go for the frontal this thing, recess surgery, and you don't want to. You are not, supposing you are not well versed with 70-degree, using 70-degree scope and angle endoscope and angle instrument. Angle instrument you will need angle endoscope. So what we do, we try to take a flap from here. We take a triangular flap which is based on the axilla, posteriorly based. We remove it, we deposit it here, punch out with the help of kerosene only, it will not take drill at least. We punch out this portion of the bone, and then we can get a view of correctly, a view of uncinate also can be removed, or if you want to do any other further step. So as this area is widely open now, you can use the 0-degree endoscope to go further. Or sometimes, like this is shown in this picture now, they have described in hormone, this can be used as a mini refine, or stenting can be placed, or even wash can be done through this opening. But usually only this portion is not opened like that. We remove uncinate, we do again as I cell, and then we want to do further, we do it this way. Follow up after surgery, important points are, uh, firstly, for few weeks it has to be frequent, this thing, depending upon how the patient is behaving. You have to, without adding more trauma, you have to you will have to remove any collected blood, crust, or dried crust. You have to try to remove those. If you have put stenting, then also you have to see if not, it's not drying up, the patient is taking the washes regularly. Second, this slide I have shown na, in few patients, first you follow up, uh, uh, first few steroid irrigations are given in the early post-operative period for few months, maybe 6 weeks, and then when you see that mucosa has stabilized, there is no more crusting, there is no more edema, then you can go for saline irrigations. Saline irrigations also, there are some ways, the picture which I shared, technique. So those technique can be taught to them, and these are for difficult frontal surgeries. For draft 1 or just frontal sinusotomy, just regular follow-up like we are following up other maxillary sinus or ethmoid cavity, that will do. But for frontal, especially when we are doing draft or removal of an extending tumor, especially for draft, you have to see this kind of, in difficult post-operative frontal patients. This is a Magindy's technique of putting steroidal maybe solutions or nasal irrigation. This is one way, and this is another way, where kneeling Mecca position, and this one. These are the three techniques. These you can show to the patient when we are you are dealing with difficult frontal post-op patients.
I think there is no more query, ma'am.
Okay,
Ma'am, one query came just now from Dr. Rehan.
draft procedures. So again, I'll go back to my slide. Draft procedures. So earlier, I think you guys are well aware of this. Earlier, draft procedure used to be done by microscopes. Microscopes using 300 lens. These draft procedures were done. Then they were known to be as, I think, Lothrop procedures. And now when draft started using endoscopes for it, they are termed as draft procedure. So draft is nothing. Draft one is just clearance of the frontal recess cell, like frontal sinusotomy. Draft 1A, draft 2A is removal of the frontal sinus floor. This is frontal sinus, removing the floor of the frontal sinus in between middle turbinate and lamina preparatia. So there is a wide new ostium now for post-op surveillance or for drainage. Draft 2B is again removal of the frontal sinus septum along with superior part of the frontal sinus floor along with removal of the septum also from lamina preparatia to nasal septum. Floor of the frontal sinus, removal of the floor of the frontal sinus from lamina preparatia to nasal septum. See this one. This is again a big ostium. Now when this procedure is again repeated on the other side, this is draft 3. And the modifications I have told, modified hemilothrop, these are for special situations and these are modifications not practiced that much nowadays, but I think I've taken it from Otolaryngology clinics of North America. There's a whole chapter over the modifications or the this procedure, frontal sinus dilating procedures, frontal sinus ostium dilating procedures, modified hemilothrop, modified minilothrop. Only this diagram will help. You guys can take a click or screenshot of this thing. And modified subrotal. These are in special situations, uh, done in special situations only. So I think I'll meet you guys again on 23rd of Feb. I think I have again a lecture on phonosurgery. So I've given you my email. If you have some doubt about this presentation also, you can put up there. And if you want to listen or if you want me to talk on something specific in phonosurgery, you can mail me also so that I can incorporate that one in my next lecture.